Hey, for my clinical pattern project, I had patellofemoral pain. Patellofemoral pain is often defined as insidious onset of anterior knee pain that limits activities of daily living involving knee flexion. So for prevalence, it is most common among young people, so young adults, and adolescents, with the peak age being between 12 and 17. It is also more common in women. So for outcome tools, one would be the anterior knee pain scale, and then another would be the knee injury and osteoarthritis outcome score. The COOS, they have one with a patellofemoral pain subscale. So onset, like I said, is an insidious onset that can be caused by repetitive overloading, overuse, malalignment, and or muscle imbalances, specifically weak hip abductors, and it can be multiple of those reasons or just one. Just depends on the patient. Aggravating factors are going to be things with knee flexion, so prolonged sitting, stairs, squatting, kneeling, lunges, and then for easing factors, it would be rest and ice. There isn't really a specific 24-hour pain pattern, but of course the patient's going to have increased pain throughout the day as they put themselves in positions or do activities that involve more knee flexion. For systems review or in review of systems, you don't need to do one specifically, but you do want to ask about fevers and unrelenting night pain and fatigue, just because you want to rule out osteosarcoma of the knee. For precautions and contraindications for the physical exam, mainly you just want to avoid compressive forces on the knee, and to do this what you want to do is avoid going past 60 degrees of knee flexion and closed chain knee flexion, so no deep squats or lunges. And then when doing resisted open kinetic chain knee extension, you don't want to go into full extension, you want to stay in that 90 or 40 to 90 degrees of knee flexion, and those are just to limit the compression and pain on the knee. For the physical exam, for active movement testing, often they have decreased hip range of motion in multiple directions, and it just depends on the patient. And they could also possibly have decreased ankle dorsiflexion range of motion. For passive range of motion, it'll be similar than it was for active. And then for resisted, they could have weak and painful knee extension, CUT, and weak and painless hip extension, abduction, and external rotation, CUT. For accessory mobility, it's really possible for them to have hypo or hypermobility of the patella, it just depends. And then also they could have hypomobile posterior glide or the talocrural joint related to their decreased dorsiflexion. For neuro, there aren't really any significant finds there. For special tests, there's 3 common ones. Patellar tilt test, which has a sensitivity and a specificity. It has a sensitivity of 43% and a specificity of 92%. Reproduction of retropatellar pain when squatting has a sensitivity of 91 to 94% and a specificity of 46 to 50%. And then there's the eccentric step-down test, which has a sensitivity of 42% and a specificity of 82%. For palpation, it can be painful when you palpate either their distal or medial aspect of their patella, and then also the medial femoral condyle. You also want to palpate the musculature around in the area, just get a feel for it, because they could have, specifically with the vastus medialis, they could have decreased tone and activation. Some differential diagnosis would be patellar tendinopathy, patellofemoral osteoarthritis, distal IT band syndromes, and then could have referred pain from the hip or other hip pathologies. For diagnostic imaging, there is really no gold standard because patellofemoral pain is not diagnosed with imaging. They could do a radiograph or an MRI, but that would just be to rule out other conditions. Signs and symptoms indicating referral to a physician would be if they had a direct blow to the patella and it's painful and swelling, it might be a patellar fracture, and you would want them to be seen for that. Surgical indicators, if they have repeated patellar subluxations and nothing is getting better with therapy, surgery may be an option, although it is very rare for this condition, but some options for that could be either debridement or lateral release of the retinaculum in that area. But again, those are quite rare. But that is all you need to know about patellofemoral pain.